Greetings from Indian Journal of Anaesthesia. I am Dr. Kiran Mahendru, IJA blogger, and I'll be presenting an article published in the April 2025 issue of IJA. It is on continuous peripheral nerve block in patients with proximal femur fracture, a randomized comparison of 3 techniques. Proximal femur fractures, often caused by high energy trauma following road traffic accidents, are associated with severe pain that will increase the patient morbidity. Peripheral nerve blocks used in these patients undergoing lower limb surgeries offer better post-op pain relief than the opioid-based analgesia. Analgesic efficacy of single-shot femoral nerve blocks and fascia iliaca compartment block techniques have been described in hip surgeries as well as femur neck fractures. Femoral nerve block, it is a reasonably simple and easy to perform block, and it spares the area supplied by the obturator and lateral femoral cutaneous nerves. The fascia iliaca compartment block, on the contrary, deposit the local anesthetic in the plane between fascia iliaca and the underlying iliacus muscle, and it provides a better coverage of the areas supplied by the femoral nerve, obturator nerve, and the lateral femoral cutaneous nerves. The fascia iliaca compartment block can be administered either via conventional infrainguinal approach or by utilizing a modified suprainguinal approach. The suprainguinal fascia iliaca block technique has a more proximal spread of the local anesthetic covering the iliac fossa. Now, postoperative analgesic efficacy of this continuous fascia iliaca compartment block compared with continuous femoral nerve block in proximal femur fractures has not yet been evaluated. The primary objective of this study was the number of rescue analgesic doses administered in a 24-hour postoperative period, and the secondary objectives were postoperative VAS scores, time to first request for rescue analgesia, post-op 24-hour opioid consumption, the block performance time, the ease or feasibility of block administration using a 4-point Likert scale, and side effects, if any. The hypothesis of the study was that postoperative analgesic efficacy of continuous suprainguinal fascia iliaca block would be superior to the infrainguinal approach and the femoral nerve block. The study has been given the ethical approval. It has been registered with the CTRI. It is a randomized trial conducted in a level 1 trauma center of a tertiary care hospital from March 2019 to May 2022. The study included adult trauma patients belonging to ASA physical status 1 or 2 between the age group of 18 to 60 years who were scheduled for proximal femur fracture fixation using intramedullary femur nailing under general anesthesia. The patient with history of substance abuse, chronic analgesic therapy, infection at the block site, unstable hemodynamics, polytrauma or vascular injuries, impending compartment syndrome, any psychiatric illness, pregnancy, or elderly patient with comorbid conditions, and allergy to any of the drugs used in the study were excluded. Preoperatively, VAS scores were explained to the patients, and the patients were randomized into 3 groups: continuous femoral nerve group with 20 patients, suprainguinal group with 20 patients, and infrainguinal group with 20 patients. Computer-generated codes were used, which were kept in a serially arranged sealed envelopes in a white container. The envelope was picked up by an independent investigator who did not participate in further patient management. The patients were monitored using ASA standard monitors, and balanced general anesthesia was given. For intraoperative analgesia, intravenous morphine in the dose of 0.1 mg per kg was used. Before extubating the patient, ultrasound-guided fascia iliaca compartment block with either the suprainguinal or infrainguinal approach or femoral nerve block was performed as per the randomization code. It was given by an experienced anesthesiologist who was well versed with the technique and had a minimum of 5 years of experience post the senior residency. Study subjects and the anesthesiologist collecting the outcome data were blinded to the group allocation. Following the tracheal extubation, all the patients were administered a standard post-op analgesic regime containing IV paracetamol 1 gram given every 6 hours. For giving ultrasound-guided continuous femoral nerve block, a high-frequency, well-lubricated ultrasound probe was used, which was placed in a transverse direction below the inguinal ligament. Femoral nerve was identified lateral to the femoral vessels, and an in-plane approach was used using an 18-gauge 100 millimeter echogenic needle inserted from lateral to medial direction towards the femoral nerve. The needle was placed in the lateral part of the visualized femoral nerve, between the femoral nerve and the superior part of the iliopsoas muscle. A weight-based bolus dose of 0.2% ropivacaine was given. Following this, a 20-gauge catheter was inserted through the needle and advanced 3 to 5 centimeters beyond the needle tip to be localized at the lower midpoint of the femoral nerve. And the needle was then withdrawn over the catheter. This is the ultrasound image showing the femoral nerve, the femoral artery, the femoral nerve block catheter, which is present below the femoral nerve and above the iliopsoas muscle. For ultrasound-guided continuous infrainguinal facial iliaca compartment block, a high-frequency, well-lubricated ultrasound probe was used, placed in a transverse direction over the anterior thigh below the inguinal ligament to identify the femoral artery, iliacus muscle lateral to it, covered by the fascia iliaca. If the division of the femoral artery was visualized, the probe was moved more cranially. The echogenic needle was then inserted in plane of the ultrasound beam and advanced until the tip was underneath the fascia iliaca. After negative aspiration, 0.2% ropivacaine was given as bolus based on the weight of the patient. The catheter was then inserted and advanced 3 to 5 centimeters beyond the needle tip, and then the needle was withdrawn over the catheter. This is the ultrasound image of infrainguinal fascia iliaca block, where you can see the sartorius muscle, the iliopsoas muscle, the local anesthetic spread, and the catheter with the femoral nerve. For ultrasound-guided continuous suprainguinal fascia iliaca compartment block, again a high-frequency, well-lubricated ultrasound probe was placed perpendicular over the inguinal ligament, slightly inferior and medial to the anterior superior iliac spine. A thick white anterior inferior iliac spine and more superficial dark iliacus muscle with fascia iliaca covering its surface, along with the bow tie confluence of internal oblique, which is cephalid, and sartorius, which is caudate, was identified. The needle was introduced parallel to the probe in a caudal to cranial direction in plane and advanced until the tip was placed underneath the fascia iliaca. Again, 0.2% ropivacaine, weight-based bolus dose was given. The catheter was inserted and advanced 3 to 5 centimeters beyond the needle tip. So this is the ultrasound image of continuous suprainguinal fascia iliaca block, where you can see the sartorius muscle, the internal oblique muscle, the local anesthetic spread, the presence of the catheter, and this red circle is the deep circumflex iliac artery, and below is the iliopsoas muscle. Now, for the weight-based dosing of the ropivacaine, 30 ml of the drug was used for a patient with a weight more than 70 kg, 25 ml for a patient with a weight 50 to 70 kg, and 20 ml for a patient with a weight less than 50 kg. Now, following catheter insertion, a continuous infusion of ropivacaine 2 mg per ml was given at 10 ml per hour for next 24 hours. The block performance time was noted. The ease of performing the block was noted as per a 4-point Likert scale. In the postoperative period, all patients were assessed for presence and severity of pain using the VAS score on arrival at the recovery, and thereafter at 2, 4, 6, 8, 12, and 24 hours by an investigator who was blinded to the group allocation. The VAS scores were kept at less than 4. And in case the VAS scores were more than 4, IV morphine in the dose of 0.05 mg per kg bolus was administered. The number of rescue analgesic doses required, the time to administration of first rescue analgesia, and 24 hours opioid consumption was recorded. The quality of pain relief was recorded as excellent, very good, good, or poor at the end of the 24-hour study period. Any adverse events like nausea, shivering, pruritus, if reported, were recorded. The sample size was calculated using the OpenEpi software based on the previous literature and from the author's clinical experience, where they hypothesized that proportion of patients requiring more than one dose of rescue analgesia will vary from 5 to 10% in suprainguinal group, 10 to 20% in infrainguinal group, and 65 to 75% in the femoral nerve block group. Based on this, a minimum of 15 patients was required in each group, and to allow for possible dropouts, the authors included 20 patients in each group. SPSS 29 version was used for statistical analysis. Now, this is the concert diagram for the study, where 65 patients were assessed for eligibility and 5 were excluded because of the refusal to give consent for the study. And 60 patients were randomized with 20 each in femoral nerve group, infrainguinal, and the suprainguinal group. Now, this is the table showing the socio-demographic characteristic of the study participants. There was no difference in the three groups based on this socio-demographic characteristics. Mean duration of surgery was noted to be 135 minutes with a standard deviation of 12.8 minutes. Now coming to the primary outcome, the rescue analgesic consumption was lowest in suprainguinal fascia iliaca group. The time to first dose of rescue analgesia was quite long for the suprainguinal group, which was 12 hours, whereas it was 4 hours in femoral nerve block group and 5 hours in infrainguinal group. The number of rescue analgesic doses required were also least in the suprainguinal fascia iliaca compartment block. No difference was seen when comparing the block performance time, the ease of performing blocks, and any side effects noted. Now, comparing the post-operative VAS scores at different time points, it can be seen that there was a statistically significant difference in the VAS scores at 0, 2, 4, 6, 8, and 12 hours. And the scores were significantly less in the suprainguinal group when compared with the femoral nerve block and the infrainguinal group. Only mild pain was experienced by the patients in the suprainguinal fascia iliaca compartment block, and 75% of the patients reported that the pain relief was excellent. Now, the results of this study indicate that a continuous suprainguinal approach to fascia iliaca compartment block provides superior analgesia compared to continuous infrainguinal block or femoral nerve block. As the primary outcome, the least number of rescue analgesic doses were administered in the suprainguinal fascia iliaca compartment block. Lower VAS scores and a higher patient satisfaction scores were also noted in this group, and this points to its superiority. The block performance time was comparable in the three approaches, with no untoward side effects noted in any of the groups. The femoral nerve block is a commonly preferred approach to provide analgesia for lower limb surgeries because it is easy, simple, and the efficacy makes it a popular choice. Inadequate pain relief experienced by the patients in this group could have been because of the sparing of the lateral femoral cutaneous nerve and the obturator nerve. They can either be blocked individually or the drug can be deposited in the fascia iliaca compartment. The fascia iliaca compartment block is an effective and safe analgesic technique with a short learning curve. The fascia iliaca compartment block lowered the systemic morphine consumption and resulted in fewer complications as compared to epidural analgesia in the previously reported studies. The results in this study are due to more proximal deposition of the local anesthetic following the suprainguinal block, resulting in better spread to the three main branches of the lumbar plexus. In one of the previous studies, MRI imaging shows a greater cranial and medial spread of the local anesthetic following the suprainguinal approach rather than the infrainguinal approach. Majority of the patients in this study were young males admitted following the road traffic accident with an intratrochanteric fracture femur scheduled for intramedullary femur nailing. Single shot peripheral nerve blocks provide analgesia for a limited duration. Therefore, the authors decided to provide continuous analgesia to the patients by inserting peripheral nerve block catheters. To maintain a homogeneous patient population and better assess the analgesic efficacy of the blocks, the authors included only those patients who were scheduled for surgery under GA. Catheter dislodgement was not seen in any of the patients. This could have been because in-plane techniques were used for catheter insertion, which provides a longer path to the catheter, and catheters were kept in situ for only 24 hours period, and during this period the patients were immobile, therefore decreasing the chance for catheter dislodgement. The limitations of the present study are that the authors did not use a patient controlled analgesia in the study due to the non availability. The use of continuous infusion can underreport breakthrough pain episodes, but this was overcome by the protocol of the study, which required the authors to maintain a VAS score of less than 4. Maintaining a peripheral nerve block catheter in situ for long durations increases the physician workload, and hence, to test the hypothesis, they have kept the catheter only for initial 24 hours period postoperatively, when the incidence of the post-op pain is also the highest. Further studies should focus on a more cost-effective alternatives, including adjuvants like dexamethasone, to obviate the need of use of catheters. So to conclude, the continuous suprainguinal approach to fascia iliaca compartment block provides superior analgesia as seen by decreased rescue analgesic requirements and lower VAS scores and a higher patient satisfaction when compared with continuous infrainguinal approach or femoral nerve block in patients with proximal femur fractures. Thank you.